Hello class. Now I'm going to talk to you about emphysema or COPD. This is a very important disease process that I hope you really understand very well, because you will see many patients who have a history of emphysema come in with respiratory infections and even exacerbation of their emphysema. And also you have to assess with each patient how severe their emphysema is, at what degree of respiratory distress and to what extent of respiratory failure is occurring with these patients. Okay, two major changes occur with emphysema: loss of lung elasticity and hyperinflation of the lung. And remember, again, this is a chronic obstructive disease that is occurring with your patients. Emphysema is the 4th leading cause of mortality and the 12th leading cause of disability in the United States. So the incidence and prevalence of COPD is quite high, and it's a very I wouldn't say popular disease, but you'll see it very often because people are still continuing to smoke. Statistics show that by the year 2020, COPD will be the 3rd leading cause of death and the 5th leading cause of disability. 16 million people in the United States have some form of COPD. Annually, it costs our healthcare system about $50 billion a year. And obviously it would make sense that patients that have emphysema really show signs of dyspnea and definitely have a need for an increased respiratory rate, because they're trying to get the air in, and unfortunately the air is not coming out. And you have to understand too that most people who have emphysema kind of have an overlap of chronic bronchitis, which we're going to talk about in just a few minutes. It is impaired gas O2 and CO2 exchange resulting from destruction of the walls of the overdistended alveoli. Okay, now you have to think about emphysema and where the pathology is actually occurring. There is air trapping caused by loss of elastic recoil in the alveolar walls, overstretching and enlargement of the alveoli into bullae, and the collapse of small airways in the bronchioles. Okay, and you know, these bullous cysts that occur because they're over enlarged, many times I've seen these patients where they kind of burst, and you might see patients in the later stages of their emphysema develop a spontaneous pneumothorax. And I'd see a lot of these patients come into the ER in even more respiratory distress because of this spontaneous pneumothorax that occurs because these bulbous cysts actually rupture. Okay, obviously these people with emphysema are going to have a lot of cough, have chronic sputum in varying characteristics with that sputum. Sometimes it can be small, moderate to copious amounts of sputum, but sometimes it can be very thick and tenacious. And this is a problem because over time, when the sputum gets to be really thick and tenacious and a patient is really having copious amounts, this really becomes a problem with an obstruction, limiting airflow, and obviously causing the problem of being unable to eliminate the CO2. And as this pathology continues to evolve, bronchial walls start to thicken, bronchial lumen narrows, and these are why these patients have mucus plugs, and they're more susceptible to infection. Okay, but the primary disease process is in the alveoli. Okay, it's an obstructive process in which there is a poor elimination of CO2, which causes this hyperinflation, of the lungs. And over time, as the walls of the alveoli are destroyed, a process accelerated by recurrent infections, the alveolar surface area that comes in direct contact with the pulmonary capillaries continues to decrease, causing an increase in dead space. And this is dead space is basically lung area in which there is absolutely no gas exchange occurring. And so, of course, these people with emphysema will have impaired oxygen diffusion, hypoxemia, and then in the later stages, as this continues to evolve and progress, CO2 elimination is impaired, and the patients have increased CO2 and live pretty much in a state of chronic respiratory acidosis. And as the alveolar walls continue to break down, the pulmonary capillary bed is reduced in size. It's very resistant to pulmonary blood flow, so that is increased, forcing the right ventricle of the heart to maintain a higher blood pressure in the pulmonary arteries. So what you have here now is increased pulmonary artery pressures, and you have right-sided heart failure, or what we call cor pulmonale. So you can see again how the problem with the lungs kind of progresses to a problem in the cardiac system, causing your patients to have right-sided heart failure, or what we call cor pulmonale, because the origin or the pathology of this heart failure is due to the respiratory problem, causing that pulmonary capillary bed to reduce in size, making more of a force against that pulmonary blood flow increased. So the right ventricle has to work a lot harder to maintain that blood pressure in the pulmonary arteries. So of course, with right-sided heart failure, you're going to have congestion, dependent edema. Patients will have distended neck veins, and many times, because all that blood is backing up on the right side of the body, you'll have pain in the region of the liver. Emphysema can really even be explained and kind of defined in a more specific way. Sometimes we see two main types, panlobular, and we might also see centrilobular. So you may hear those terms referred to when someone is diagnosed with emphysema, but I'm not going to get into the specifics of that. I just want you to kind of know generally where the pathology is and what else is occurring, especially when we talk about the bronchial walls. But with this heart failure, right-sided heart failure, patients are very hypoxemic, have hypercapnia, which is an increased levels of CO2, and many of them, along with the respiratory problems, develop this cardiac problem called cor pulmonale, in which now the patients can manifest those symptoms that I just talked about, as well as with a lot of peripheral edema. So we think about emphysema, and we say, hey, why do people acquire emphysema? Obviously, someone who actively smokes a lot, and even passive smoking can cause someone to acquire emphysema. It might be due to some occupational hazard or air pollution, or maybe a genetic problem with a deficiency of alpha antitrypsin. And I'll talk about that in just a few minutes. But no matter what the etiology of the disease is, the manifestations are pretty much characterized by chronic cough, DOE or dyspneic on exertion, a lot of spusion, and then over time with this hyperinflation of the lungs, it leads to what we call a barrel chest, and that's why that anterior posterior look will change with a patient, and they'll be very barrel chest because those ribs start to kind of move outward because of the hyperinflation of the lungs, and they kind of start inverting downward, and that causes the chest to look like a barrel. Many times you'll see a person with severe emphysema kind of lean forward because what they're doing is trying to use all those accessory muscles to breathe. These patients over time become extremely fatigued. I mean, even the simplest things really take a lot of energy and quite a lot of effort. And you'll see that sometimes your patients with severe COPD will even have a difficult time even just eating. And that's why a lot of times when they're going to do something like eat or even do a walk or whatever type of activity that could lead to some kind of exertion, we might advise them to maybe use a bronchodilator to kind of open up those airways. Won't make things perfect, but it may relieve a little bit of that dyspnea and help a person better much able to eat or do something that requires a little more energy and oxygen. You know, the fatigue really leads to all kinds of deterioration in all their dimensions of cognitive thinking, physical activities, as well as that psychosocial. You'll see a lot of people that have emphysema really become very depressed, really have a poor quality of life. And sometimes this can happen early on in the disease process, causing someone to be on, complete disability, unable to work, and really unable to function very well, and really have a hard time just doing normal activities of daily living. And many times what you're going to see as a nurse who cares for these patients, they come in with an exacerbation of their COPD, probably most of the times because of infection. They'll get like a pneumonia, and it really just makes their respiratory condition so even more poorly presented, in which they have more extreme dyspnea and just really have a hard time breathing, and really along with someone who doesn't have COPD that gets some type of respiratory infection, but it's so much harder on them because they have such deterioration of their lungs and all the structures that go along with the art of breathing, and of course with the alveoli that are so important in the diffusion of gases. And kind of touching on a little bit when we talk about the healthy lung. Within the healthy lung, there's what we call protein-degrading enzymes called proteases. And those are present to destroy and eliminate all the protein-based particulates, matters, and organisms that we actually inhale on a day-to-day basis. And if higher than normal, they can actually damage the alveoli and the small airways by breaking down elastin. So high protease levels causes the alveoli sacs to lose their elasticity and the small airways to collapse or narrow. And some are actually destroyed, and others become large and flabby with decreased areas for ineffective gas exchange. So that's what we mean by the AAT enzymes, okay, in regards to a genetic problem, and not necessarily due to the fact that maybe someone smoked for many years and smoked a lot of cigarettes. But the bottom line is, no matter what that etiology is of why someone does develop COPD or emphysema, there is a trapping of air in the lungs, and the causes of air trapping are a loss of elastic recoil. Remember, the lungs kind of inflate and deflate kind of nicely under normal circumstances and with a healthy lung, but because of the damage of that lung and the elasticity, you don't have that elastic recoil continuing when someone breathes, and that loss of elastic recoil in the alveoli walls, and what happens is there's an overstretching and enlargement of the alveoli into those air-filled spaces, and I've already talked about those called bullies, and a collapse of some of the small airway bronchioles. So I just wanted to kind of talk about that in regards to the genetic end of it. And when we talk about alpha antitrypsin deficiency, it's less common problem, but it can be an important risk factor for COPD. And as I said before, there's a special enzyme, alpha antitrypsin, is made by the liver and is normally present in the lungs. And one purpose of this alpha antitrypsin is to regulate those proteases, as I talked about, and those are present to break down inhaled pollutants in organisms. And alpha antitrypsin trypsin is a protease inhibitor, and its main purpose is to prevent those proteases from working on the lungs, but only to break down those pollutants and organisms that we inhale. And so normal amounts of this alpha antitrypsin deficiency depends on a genetic factor. And it's basically a recessive gene, so you might have one bad and one good. And so if maybe your mother has the bad gene and your dad has the good one, then the person can actually make enough AAT to prevent COPD unless there's a significant exposure to cigarette smoke and other precipitating factors. But if both parents have the recessive gene, someone would be able to develop COPD at a very early age if not exposed to smoke or other irritants. We see about 100,000 cases of this a year, and really it's not only limited to the lungs, but a person can have other problems in other organs, the skin, the liver, and the lungs. Okay? So that's pretty much the pathology behind emphysema. And our big concern, obviously, when the patients come in is the fact that they're not properly being oxygenated, which makes sense. But you have to understand with what kind of lungs you're working with. These are very damaged lungs. We already have a deficit on board because of the problem and the pathology that's occurring in the alveoli, as I've just talked about quite frequently. And obviously we want to oxygenate those patients as best as we can. You know, some of these patients we may never see a pulse ox higher than 90%, especially patients that are in the later stages of their emphysema. But our other concerns are some of the complications that occur with emphysema. And pneumonia is a big one, because sometimes that's what brings that patient in, because they're even more short of breath and more in some kind of respiratory distress. Atelectasis is another one. Pneumothorax I've talked about, where those bolus cysts or those blebs kind of burst because they're overinflated. We talked about pulmonary artery hypertension or right-sided heart failure. And, these are things that are very concerning. And many times, too, when the patient comes in with emphysema, we see some cardiac issues develop. Many of them go into what we call an atrial fibrillation, which we'll talk about when we get to the cardiac system. And, of course, now we've got poor oxygenation of the heart muscle, which can lead to really severe cardiac issues over time. And one I've already talked about is the changes in the pulmonary circulation, causing the right side of the heart to have to work a lot harder. And this is why many of these patients come in with right-sided heart failure. We'll talk in a few minutes about some of the medications that we might use for our patients with COPD. Many of them are very similar to our patients that have asthma. We can use systemic drugs as well as some of the inhaled drugs. Many times First of all, if they are smoking still, we strongly and highly encourage them to quit smoking if they possibly can. But we want to be kind and non-judgmental about smoking, because some of these people are so addicted to cigarettes. It's very hard for them to quit, even when they're in their later stages of their emphysema. They do fairly well with some of the bronchodilators, the MDIs, that help open up those airways as best as that they can. We also might see your patients a lot on corticosteroids because, again, they have a lot of inflammation, especially if they come in with pneumonia or some of the infections that go along with it. We're also trying to reduce some of that inflammation in the airways also. The big problem, as I said before, is the thick, tenacious secretions and mucus and sputum. So mucolytics really help to thin those thick secretions, making it easier to cough up. Sometimes while these patients are in the hospital, they may be on a nebulizer. They might also take guaifenesin to help, bring up those secretions, because remember, with some of the severe shortness of breath that these people experience, many of them over time have really had poor nutritious eating habits, and so because it takes such an effort to eat, many of them become very debilitated, very thin, lose a lot of muscle mass. So it's a big effort just to eat. So that's why a bronchodilator before meals might be good. One thing to kind of stress is the fact that patients with COPD really do not respond well to masks, even though many times they might need that high percentage of oxygen, because they just feel very claustrophobic. So many of them are unusually continuous O2 specs. Remember, we got to be very careful not to increase that FiO2 too high to, again, knock out their hypoxic drive. Some of them may be enrolled in some kind of pulmonary rehab, exercise conditioning. Some of them, because of the effort to cough up sputum, may need to have assistance with suctioning. Just really watching their respiratory status, evaluating their pulse ox. What's the best we can do for this patient, especially if someone over time has really have deterioration of the alveoli walls. Positioning is a great way to hopefully get them to have the best respiratory effort that they possibly can, and really teach them about how to effectively cough, because if they're not going to do it effectively and they're constantly coughing, it just really wears them out physically, and really it's really for nothing, because they're not actually able to bring anything up because they're so exhausted and quite tired from the effort it takes to bring up some of these very thick and tenacious secretions. Plus, you have to kind of consider too, if they do have these thick secretions, think about their oral care. Maybe they aren't in the mood for a nice steak dinner, but we can sure offer them some good oral care, and maybe things that are easy for them to eat to give them calories to keep a fairly decent nutritional status with them, and that kind of thing. So those are all things to consider, and make sure they have fresh water. Hydration is very important, and then really to monitor if some of them do have what we call that core pulmonary and that right-sided heart failure, that we really keep tabs on some of that edema, peripheral edema that they may have. And then, of course, assessing their lung function, listening to breath sounds as well as heart sounds. And, all these patients definitely should be on daily weights as well as accurate intake and output. all these issues that and problems that we talk about with all the systems that we will eventually talk about in this course really all need some type of specific nutrients or some kind of teaching about what foods are best for them in regards to their disease process. And you have to think about patients with COPD, okay? We know that teaching that we might do with a patient who has COPD, changing their eating habits will not cure COPD, but it can help these patients feel a little bit better. And that's why we might want to bring a registered dietitian in to provide in-depth nutrition guidance and really tailor the educational information to meet the needs of your specific patients and help kind of create and follow a personal action plan. Because we know food is essential for the fuel of our bodies needed to perform all the activities, including breathing. And we know these patients with COPD have a much harder time to breathe. And our body uses food for energy as part of a process called metabolism. And so during metabolism, food and oxygen are changed into energy and carbon dioxide, and you use energy for all of our activities from sleeping to exercising. So that's why we know the common nutrients needed, carbohydrates, fats, and proteins, that affect how much energy we will have and how much carbon dioxide is produced. And remember, if we go back to thinking about blood gases, as I talked about in some of the earlier lectures, carbon dioxide is a waste product that leaves your body when you breathe out. If there is too much carbon dioxide in your body, you might feel weak. And that's why these patients do feel weak, because they retain that CO2. So breathing requires more energy for people with chronic obstructive pulmonary diseases. The muscles used in breathing might require 10 times more calories than those of a person without COPD. And I really want you to think about that and keep that in mind. So good nutrition helps the body fight infections, and chest infections are illnesses that often lead to hospitalization for people with COPD. So it's important to reduce their risk of infection by following a healthy diet. So this is why we want to encourage this to our patients, when they get home after we've pretty much stabilized them. So maintaining a healthy body weight is really important. If they're overweight, and we don't really see this in the later stages of COPD, but if they are overweight, our lungs and our heart have to work much harder, and it adds additional problems with breathing. So people with COPD use more energy while breathing than the average person. Therefore, the pulmonary muscles in someone with COPD might require up to 10 times more calories, as I said before. So we want to be careful of a lot of carbohydrates, because many times those carbohydrates lead to a end product of carbon dioxide, and we don't want our patients to have additional carbon dioxide on board. Along with proper nutrition, we want our patients with COPD to drink plenty of fluids. Limit a lot of the caffeine, especially if they're on some of the theophylline medications. Remember how I talked about earlier how we really want to encourage our patients not to drink an excessive amount of coffee or some of the caffeine-related drugs. And if our patients with COPD do have heart problems, we might have to limit their fluids so they aren't retaining fluid and cause extra stress and pulmonary problems. So I just kind of wanted to, kind of bring upon about, the types of food that our patients with COPD need. You might not think it's important, but it truly is important, seeing that it takes so much effort to breathe for a patient with COPD than someone who does not have the disease. Looking on this next strip, let's talk somewhat about, bronchitis, okay? What is bronchitis? Okay, it's an inflammation of the bronchi and bronchioles caused by chronic exposure to irritants, especially tobacco smoke. Again, with bronchitis, it triggers inflammation, vasodilatation, congestion, mucosal edema, bronchospasms. And remember, this is a disease that only affects the airways rather than the alveoli again. I mean, it makes sense. Bronchitis, bronchioles, okay? And I can't stress this enough. One of the hallmark manifestations of patients with bronchitis is the production of large amounts of thick mucus, okay? And these bronchial walls really thicken 2 to 3 times their normal size. It does impair airflow, and with this thickening produces a lot of thick, tenacious mucus that further causes impaired gas exchange, okay? I already talked much about the alpha-1 antitrypsin deficiency. Remember, it is a less common problem when we talk about COPD. Please make sure that you read about that in your book, okay? But please understand that many of our patients who have emphysema will have chronic bronchitis. And with chronic bronchitis too, with this chronic inflammation, increases the size of some of the mucus glands, and that's why the big hallmark manifestation of bronchitis is that large, thick mucus. PaO2 will be reduced, and of course, again, PCO2 will be increased. Okay, so that's chronic bronchitis. About 14 million people have bronchitis. Again, very much seen in patients that have emphysema. The complications that go along with bronchitis, is the hypoxemia, acidosis, and of course decreased cellular function because the person is not being oxygenated well. So, and again, think about all the patients who do have emphysema. You might want to also consider that they have chronic bronchitis. And many times these patients have underlying comorbidities of a lot of cardiac problems, okay? And again, with COPD, these are many of the complications that I've already touched upon. Hypoxemia makes sense. Affects all tissues and affects the brain. Affects, the main organs in the body, the cardiac system. Very acidotic. Respiratory infections. Increased mucus and poor oxygenation. Cardiac failure, I've already talked about why cor pulmonale develops. Please understand the pathology behind that. If you don't understand it, let me know. Reread it in your book again, because there is a reason why cor pulmonale develops with your patients with COPD. Cardiac dysrhythmias, decreased O2 to the heart muscle, other cardiac diseases, drug effects, or acidosis. Remember, if you go back to that first PowerPoint when I talked about ABGs, what are the effects of respiratory acidosis on the cardiac muscle? Remember, that kind of relates to what's occurring with your patients who have COPD. Again, looking at our patients and their clinical manifestations, looking at their history, risk factors, ethnic background. Look at the general appearance of your patient with COPD. Many times you can look at someone and kind of tell how advanced their COPD is. And every time they get a reoccurring infection, it further destroys all that. Sorry, I just had to sneeze there for a minute. Many of them will be very thin, debilitated, emaciated. You can really tell by their posture how well they get around, how mobile they are, muscle mass, and overall hygiene. Look at the respiratory changes over time, changes in the chest size, fatigue, what's their specific breathing rate and pattern, and what is their cardiac status, heart rate, rhythm, swelling of feet and ankles. Assess nail beds. Are they chronically cyanotic, oral mucosa membranes? If they have a lot of these signs and symptoms of right-sided heart failure, you're going to see swelling of the feet. You might see some jugular vein distension, even, an engorged, liver, anything that brings that back up to the right side of the body. And again, I've talked about how dyspneic your patient is. This is the dyspneic assessment guide, indicates the amount of shortness of breath you're having at the time by marking the line. Where is your patient on the spectrum? How dyspneic are they? Again, looking at lab values, of course, we're going to truly assess ABGs, and you might see these done 2-3 times a day, depending on what we've done for that patient, how much distress they're in, what kind of interventions we've provided. Maybe we've been changing O2 modalities on these patients to kind of help oxygenate them at the best that we can. So we're kind of redoing and repeating ABGs to kind of see where we are with those patients. Remember, we probably will never get these patients perfect because of the severe lung disease that they have, but we're trying to do the best we can. What about sputum? Have we sent down those samples to kind of see if they do have an infection, what kind of antibiotic we're going to treat them with? What's their CBC like? Are they anemic? Do they have polycythemia? Because what you'll see happen is when the patient's hypoxic, that triggers more red blood cell formation, and sometimes we see the patients have increased red blood cells, and that's what we mean by polycythemia. Hemoglobin and hematocrit blood test, are they dehydrated also? Sometimes we'll see elevated hematocrit levels on these patients. Are they anemic? What's their electrolytes? Their serum AAT levels? What's their chest x-rays like? And are we going to repeat ABGs on them? The chest x-rays really kind of compare and contrast maybe their last chest x-ray. If they haven't been in the hospital for a while, we kind of look at their cardiac and lung structures to kind of see what's going on. Many times you'll see within that chest x-ray that hyperinflation and more of a flattened diaphragm. You'll be able to pick that up on the chest x-ray. As far as electrolytes, sometimes assessing their renal status, looking to see what their phosphate levels, potassium levels, calcium levels, and their magnesium levels are. Again, depending on where we're at with the severity of their COPD, airway management, monitoring patient at least every 2 hours, especially if we're really being aggressive and providing, medications, oxygen therapy, maybe nebulizer treatments. Remember, be careful of increasing the oxygen flow rate over 2 liters. Remember, they need those low O2 levels to keep that hypoxic drive intact. Making sure we're giving them the medications that's been ordered and kind of watching to see if there's any serious side effects, especially if we're giving mentholxanthines like theophylline or even some of the bronchodilators with their nebulizer treatments. These patients might be candidates for pulmonary rehab, kind of teaching them about exercise training, okay? And again, the same types of medications that I've already talked about with asthma. I won't repeat these, but you need to know these. How do they act? Why are we giving them to the patients? What are the serious side effects we might see? Because these patients will be going home on many of these medications, and they need to understand their drug therapy, their personal drug therapy plan, and especially if they're going home on steroids. You know, maybe they're going to go home on an oral deltazone or prednisone. They need to know the importance of not stopping those drugs abruptly. They also need to know about coming in periodically if they're on like a theophylline or a Theodore. They might have to be coming in for a theophylline level. Also teaching them the importance of, you know, not drinking excessive amounts of coffee with caffeine or other carbonated drinks with caffeine in it. So these are things that I want to make sure that you understand, as well as what you need to be teaching your patient. Pulmonary rehab is great because you know, it's really helpful to keep respiratory muscles strong, because that's what they need to help them breathe. Okay. Surgical management, lung transplantation for end-stage patients, preoperative care and testing. These are possibilities. It just depends on the patient and if they're good candidates. They do a lot of very in-depth screening to determine who would be a good candidate for this. It's a long surgery, and obviously they need a notable match and donor. A lot of the assessment for breathing, for the breathing pattern, and you know, if they come in with a respiratory infection, we need to teach them about the importance of pneumonia shots, flu shots, because obviously without a good diet and with the debilitation of their lung function, they're going to be very prone to infections. Teaching them about specific breathing techniques, diaphragmatic, abdominal, or pursed lip breathing. Your book does a nice job of explaining that and kind of showing pictures of what we teach our patients, because this is very important. We want to do everything we can to give them the optimal tools and knowledge to be able to breathe the best that they can possibly breathe. And positioning is also huge to help alleviate a lot of the dyspnea that they face. Teaching about how to preserve energy through the day, you know, doing a little bit here and then resting. You know, they're not going to be able to work continuously because they don't have the energy and the capacity to work at that level. But we can teach them about energy conservation as well as frequent rest periods. And again, I've already gone into a lot about the nutrition, prevent protein calorie malnutrition through dietary consultation, monitor weight, skin conditions, and serum prealbumin levels, looking at their protein levels, and how to manage their dyspnea as to what degree that we see with these patients. And food selections to prevent weight loss. Maybe they really love milkshakes. That might be a great way to get those calories and maybe protein rather than eating a steak, which could be very exhausting and time consuming. Patients do not have that kind of time and the energy to eat that kind of food, but maybe through other likes of certain foods that they can get in some of those calories that they very well need. Anxiety is another big part of someone with COPD. Important to have patients understand that anxiety will worsen symptoms. I mean, think about it. If you've not been able to breathe very well, no wonder someone's anxious. And this is a disease that not only affects patients themselves, but also their family. And they really do need a lot of support from their family and friends. Just talking about how activity is very hard for them, and how activity intolerance becomes a big problem in their activities of daily living. really about pacing their activities, not to rush through activities, gradually increase activity, and really many of these patients will be going home on supplemental oxygen therapy. Again, preventing respiratory infections, especially for the older patient. Avoid large crowds, pneumonia vaccine, and a yearly influenza vaccine. I think the pneumonia one is every 5 years. And long-term use of oxygen, pulmonary rehab, and really hoping that they understand a lot about their medications and how to reduce the chances of reoccurring infection, because every time they get reinfected, it further deteriorates their lung function. So I hope now you have a much better understanding of asthma, COPD, and bronchitis, okay? I'm going to just talk about primary pulmonary hypertension, and then I'll conclude this lecture, and then I'll just tape a short lecture regarding some of the other incidental respiratory problems that you may see with some of your patients. But primary pulmonary hypertension occurs usually in the absence of other lung diseases, very much characterized by dyspnea, fatigue, almost like angina-like chest pain. It's a pathological problem that affects the blood vessels, because what's happening is the blood vessels in the pulmonary system are constricted with increasing vascular resistance in the lung, and the heart fails, which we call cor pulmonale, and without treatment a person may die within 2 years. And how they diagnose this is by a right-sided heart cath, okay? Because what you'll see with these types of patients that have pulmonary hypertension is you'll see increased pulmonary pressures. And we can classify, after doing this diagnostic test, whether or not a person has pulmonary hypertension, either a class 1 to a class 4. We treat the manifestations and the symptoms of pulmonary hypertension with drug therapies. And what is really needed with pulmonary hypertension is the fact that we need to dilate those pulmonary vessels and prevent clot formation. So what we'll use is things like Coumadin or warfarin to prevent clot formation. Calcium channel blockers, because helps to dilate those vessels and decrease that resistance, and some of the endothelin receptor antagonists that actually help induce blood vessel relaxation, and some of the natural and synthetic prostacyclin agents, maybe digoxin, some of the diuretics, and again oxygen therapy. If we see heart involvement, hypertrophy, and cardiac output is reduced, this is when they'll use Lanoxin and some of the diuretics. If this is probably at a class 3 or 4, these patients would be very much of a candidate for a transplant also. So that's pulmonary hypertension. And just to kind of let you know that with pulmonary hypertension, it's rather a rare problem. Occurs in women between the ages of 20 to 40 years old. And as I said, it's more of a concern about blood vessel constriction and increased vascular resistance in the lung. Okay, so that is pulmonary hypertension. So this concludes this particular lecture.